Yeah, well, thank you very much, Francesco and Abd, for inviting me to talk to you today and ASO. So the title of my talk is Challenges and Practical Considerations During the Pandemic, Medical Management of Obesity and Diabetes. So of course, this is quite a lot to cover, and I've really just picked a few bits and some practical considerations and some of my own reflections with regards to this pandemic and how it's affected our patients. These are the conflicts of interest. So first of all, I'd like to reiterate again, because I think this is important, the results of the NHS England data. These have not yet been formally published, although they're under review. But essentially, we've got a very strong set of data, and this is looking at mortality per 100,000 people between 1st of March 2020 and 11th of May 2020 by type of diabetes. And of course, we had nearly 24,000 deaths during that period, and strikingly, 33% of all deaths had a history of diabetes. I think Stefan mentioned this at the beginning. And what we can see here in the curves, this is mortality versus age. It's that in the black, we have the general population, in the red, the type 1, and in the blue, the type 2s. Of course, the curves with mortality take off with increasing age, so we know that. But within that, if you have type 2 diabetes and COVID, you're twice more likely to die. And with type 1 diabetes, 3.5 times more likely to die. And then, if we look within the diabetes cohort again, and we look at the risk factors which increase your mortality, again, hyperglycemia at the top, as you can see, increase the odds ratio for mortality. So with increasing hyperglycemia, as you can see, if you have an HbA1c of 86 millimoles per mole, then your odds ratio is 1.62. And again, we looked at BMI, and the BMI, as the BMI increases, and the increase, the mortality risk again goes up, and at a BMI of 40, it's 1.64. And then another risk factor that we haven't mentioned yet is renal function, and as eGFR decreases, again, the risk really takes off. And when patients have an eGFR of less than 15, they're nearly 5 times more likely to die. So I think this is really strong data, and again, really highlights the fact that we need to manage hyperglycemia, BMI, and chronic renal disease. This is a further study. This is from China, published in Cell Metabolism recently, again, looking at a higher mortality in patients with uncontrolled blood glucose versus patients with well-controlled diabetes, well-controlled being defined as 3.9 to 10 millimoles per liter. And again, emphasizes that in the acute phase, we really have to try very hard to manage diabetes, because it does have an impact on overall mortality. So what has been the impact on diabetes and obesity services, and what have we seen, at least in the UK? Well, we know that many diabetologists and endocrinologists have been redeployed to frontline COVID-19 services, and in some cases, the last to be redeployed back. And of course, this had, a knock-on effect on services, with no routine diabetes or obesity services since the beginning of the pandemic. And even now, just over the last couple of weeks, really only medium to high-risk patients with diabetes being called, usually virtually, for opportunistic management or improvement of glycemic management, and the face-to-face limited to inpatient, foot, and antenatal. And we've seen really a patchy and heterogeneous clinical response to routine care across the nation, both in primary and secondary care. And again, with some GP practices who are still, struggling to organize bloods and see patients. In my own service, for example, we've restarted both tier 3 and tier 4 services for obesity, and we're carrying out all our consultations remotely, but we felt it was really necessary to try and really, address this huge, massive problem, both with diabetes and obesity in our patients. So the impact on everyday life for people with diabetes and obesity? Well, we know that weight loss programs and interventions such as metabolic surgery have been severely curtailed or stopped completely, and Francesca will take us through the impact of that. Of course, we've had measures, advising people not to leave their home for several weeks, which will have increased sedentary behavior and immobility in many of our patients. And the need of self-isolation may affect the quality of diet, the reliance of processed food with longer shelf life. Just this morning, I was looking at the BBC, and basically there was many patients who complained about the fact that they were too scared to go out and buy fresh produce. And we've had all the difficulties with deliveries as well. And not to mention, of course, the self-isolation, which I'm sure has had a huge psychological toll and has made also psychological support less accessible. So I think this is where we are. Now, in terms of practical points, we touched upon this, and Stefan has discussed it, and as well as the panel. But I think as we have quite a lot of GPs online, I think it's really important to perhaps just really emphasize the point about what we should be using in terms of medication to manage some of our patients. Now, of course, I've put some crosses here, and that's because I'm really talking about the acute COVID-19 illness, and when patients are acutely ill in a hospital setting. And we usually stop metformin for all the reasons that we know, although, as Kamlesh mentioned, we don't know whether we're probably doing the right thing, because metformin has got probably some inflammatory or anti-inflammatory properties or some beneficial properties, but we don't have the data at the moment. With regards to the SGLT2 inhibitors, I think, again, acutely, certainly for type 1, probably best to stop. But in mild illness, we've discussed the fact that it's not quite clear cut. And certainly for patients with obesity, I'm going to mention this in a second, obesity and type 2 diabetes, that is, the combination of SGLT2 inhibitors and GLP-1 inhibitors offers a really fantastic weight benefit. Not to mention the advantage in patients with heart failure and with established cardiovascular disease. So again, in the acute setting, I'm going to move on to GLP-1 receptor agonists, where there is a question mark as to whether we should stop them or not stop them. Sometimes we don't stop them if they're weekly, but again, if the patients are severely dehydrated, we need to closely monitor this and perhaps stop them. DPP-4 inhibitors we've talked about, they're generally safe. And of course, insulin should never be stopped. And as Stefan mentioned, we should encourage in the acute setting IV administration versus the more sort of subcut administration, which doesn't give as sort of stable glycemic profile. However, in the context of our patients, the patients with obesity and diabetes, and we know that surgery has not been an option for some of our patients. We know that many tier 3 services have not been operating, and we know that these patients are at high risk, and they may suffer a cardiovascular event from delayed metabolic surgery, as well as many other complications. So I think it's absolutely important to optimize glycemic control in these patients. And I do think that the consideration of a GLP-1 receptor agonist and or SGLT2 inhibitors, like I said, not an SGLT2 inhibitors in the acute setting, or both, if glycemic control cannot be achieved, should be considered. And I would, urge sort of primary care physicians to think about this. Now, of course, for some patients with multiple complications of obesity, dietary intervention and is important. And I think Stephanie mentioned the fact that perhaps she's not very confident about starting patients on a very low calorie diet. And is it safe to start patients on a very low calorie diet in terms of their immunity, with a sort of very short acute intervention? And I think the evidence so far suggests that it probably is reasonably safe to do so. And all the studies so far have not shown any sort of any harmful signals. But again, we need to be sensible about this and use our common sense. Some patients will require pharmacotherapy intervention for weight control. And we all know that we're very limited, certainly within the NHS, because although many pharmacotherapies, such as GLP-1 agonists and mysimba, the combination of naltrexone and bupropion, are licensed, we're not actually really allowed to use them because they're not NICE recommended, at least not for the time being. But if patients are on pharmacotherapy, they should continue their pharmacotherapy, and they should be referred to tier 3 or tier 4. And continue weight loss medication, of course, until surgery is scheduled. So finally, in terms of reflection, I think COVID-19 has highlighted obesity and diabetes as two of the most prevalent diseases in patients with this illness, with an increased risk of hospitalization and critical care admission. Specifically with regards to obesity, this is on a background of inadequate provision of obesity services across the UK. We have patchy tier 3 weight management services, where in about a third of the UK there are no tier 3 services. And even when they're present, I think they really are not able to meet demand. I've mentioned the lack of access to pharmacotherapy treatments, and of course the low number of metabolic surgical procedures, which is woefully inadequate for the demand and the need that we really need. Most of these services have been suspended during the pandemic at a time when they're most needed, and I'd urge everyone to engage, whether digitally or whichever way you can, to restart services as soon as possible. And of course, this really gives us a great opportunity for government to reassess the whole provision of obesity care and ensure that obesity services are adequately commissioned and funded in the future. And with that, I'd like to thank you and hand over to Abd.